So my talk is about a really easy flap that you can use for first web contracture. I call it first palmar intermetacarpal flap. Later I will tell you why. And so you have, for example, you have this case. This is a already operated upper hand with this first web. Let's think about the first web contracture, no? So what can you do? For flap or any kind of set plastic will not be enough. A stiletto flap will not be enough, and on the other hand, the index is not proper in this case. But I have to tell you that I don't do set plastic for the first web. Where you will need a set plastic, I do a stiletto flap because it gives you more widening and a more rounded web. Most people would say that they will do a rotational advancement Babgranco modified by Gani flap. Okay, but I'm not happy with that flap because it really doesn't give you much. Then you have a dorsal scar. In this case, it's not really ugly, but normally it's not good looking, and it gives you maybe 10 degrees of opening of the intermetacarpal angle, as you see here. And you will see that how these patients to overcome to give more wide to the pinch, they do a ulnar collateral ligament laxity, or they do a MP hyperextension. Okay, another option, of course, would be forearm flap, IOP or a radial. But so that's why, because I wasn't happy with the Gani flap, I tried not to use the forearm flaps. I thought about this new flap, and this is the flap. In this case, the flap is not advanced. It's in a proper fashion. Here you see the superficial radial vessels, but you don't need them. It's not based on them. And this is the result. Of course, you need to a skin graft. Normally take the graft from the medial arm. You have a lot of skin with a nice color. And this is the result. There is a shrinking of, always, there is a shrinking of the graft, and it becomes dark. And this is, later I did the other hand. Okay, and so I did the anatomical study in which I found very distal skin perforators. In 60% of the cases, it arises from the thumb radial collateral, and 20% in the pollex princeps. Normally, there is one perforator just very close to the edge of the web, but in 30% of cases, there are two perforators. And these are the perforators. And some people would think that this is a already described paper, but the other described papers, those thinner flaps, are based on more proximal perforators, normally from the superficial or deep superficial arch. That's how I tell the flap in our flap courses. So you take a line from the web to the FCR, then you do the ellipsoid, and then I ask them to start distally to look for the thumb ulnar collateral digital nerve. Then you move to the proximal part of the radial incision, and there I ask them to look for the thinner branch of the median nerve. And there is an interesting recent paper of Jaime Bertelli that tells you that the level of this branch is at the level of the base of the third metacarpal, at the level of the tubercle of the base of the third metacarpal. And it is true, you palpate there, and there is the nerve. This is a nerve reference. Then I asked I asked people to dissect the medial incision to cut the palmar aponeurosis, and then to look for the first lumbrical and the index radiocollateral nerve. And then at this level, you can look for the perforator, but really you don't need to do this. If you just cut the septa, the deep septa, with that is enough to glide, to move distally this flap. So you can do advance or propeller, a couple of videos, salsa, always salsa during dissection. So one is, of course, if you do gliding, you don't need to release that much. But I saw that in this flap, maybe it allows you. You have to check, of course, with clamps, but maybe it allows you for more release, and it will reach you probably fingers, index finger and thumb. Okay, so you might use this for another purposes. And this is it simulate pretending a gliding, but it's the idea came with my technique for syndactyly, that you really septa. You don't see the perforators, you don't see the vessels. You just release septa to the digital canal and to the lumbrical canal, and it moves. It doesn't look like, but it moves easily. And I invite you to our course in Colombia. It's a flap course, 2 parts, 2 days each one. This is a wonderful place for a flap course, because the quality of the cadaver story is wonderful. Okay, so this is another case, DIME, amniotic band syndrome, mild first web contracture, and the same flap. In this case, I just release the skin and I glide it. You see that you need grafting, of course, and you see here the thinner branch of the median nerve. And after releasing the tourniquet, you see it turns red, of course. And as I told you, it's so this is a flap. It's common that you have hyperpigmentation of the skin grafts. And this is another case, Osama. This we are syndactyly or malformation. I placed the flap a little bit proximal, but anyway, in this case, I did it. It was one of the first, so I did it in a proper fashion. And this is the case. This child has a very long thumb. So after this hyperpigmentation again, and after this I did a shortening of the first metacarpal, and this is another case. I've done 9 patients, 12 flaps so far. Mean the intermetacarpal angle moved from mean 18 degrees to 37 degrees. 4 of them had this hyperpigmentation. In one case, there was a distal dehiscence that I reoperated with results. And the thing is what's next? So, because if you have a really, really severe first contracture, might you have to use a forearm flap, right? but that's what I'm doing now. So like in this case, anodic band syndrome. So I did my flap, and then I did Shen's flap, the snuff box perforator flap. I had the honor to do the anatomical study for Dr. Shen in the cadaveric study. And it's based on a perforator, either from the radial artery normally, but sometimes it comes from the 1-2 supraretinacular vessels. So in this case, now I'm combining both in those severe cases with the purpose of not doing a EOP flap. I remember you that we do this, we don't do, but we try to do these PULM Talks every second Sunday of each month at 1 p.m. Spain or Madrid time. So I don't want this project to die, so I need you. Thank you very much. Okay, so who wants to guide the discussion?
Andrea. Andres.
Hi, there are some questions here in the chat. So let me see. Dr. Barda says that muscle glide is the deciding factor more than the contractibility or the color.
This is from the previous talk.
Oh, yes, I'm sorry. So you said in your talk that when you do the syndactyly flap, you don't look for the perforator vessels, but when you do this one for the first web, you pay attention to the perforators in a more
neither at
strict way?
No, neither. At the beginning I did, but because I thought about this flap to do it as a proper flap, but then I realized that it's not necessary. So I just release septa, I release, and till I have enough distal motion.
Mm-hmm. Okay, so we have more questions in the chat. Where do you see this move when someone right? Where do you see the place of this flap in initial treatment of Apert syndrome?
So not for Aperts, but for so the question is if I will choose this flap initially in Aperts. Yes, I do. I've done a few Uppers, yes. I mean, what I do now in Uppers, I have a few cases are both flaps, my flap and Shen's flap. Yes, I do. I have a few cases.
Another question, do you think is your first option in Poland syndrome?
For the first web? I think it's my first option in a moderate contracture. In a severe, the same plus the snuff box flap, and in a in a light one, the stiletto flap. This is how I manage this. If I think that I will not, if I see that I will not have enough, I would do an IOP. Great. So my fourth level would be an IOP.
Here is a question that, did you have any problems in donor area due to grafting, any contracture, for example?
No, not really. It shrinks, but no, there is no problem. The problem is that darkening of the graft, but people are okay with that.
Mm-hmm.
So there is a shrinking, but I don't see any loss of motion. I mean, I don't see any loss of supination of the thumb.
Mm-hmm.
I left
No.
my paper. I left my paper in the chat if you want to read it.
Mm-hmm. Oh, that's their tweet, so it will go down in the chat. Okay.
What else can I say? I think mostly. Okay, if there are no more questions, I think we can say goodbye. Thank you. Today we were almost all time. So today we were almost all time more than 50. I'm happy. We see you next month, second Sunday. We don't have the program yet. And thank you very much. Well, there is one more question.
Yes. Yes. He says that he likes posterior interosseous artery flap for moderate to severe contractures. What is your idea?
Yes, I like it, but what I don't like it is the longest scar at the dorsum of the forearm. Dorsal scars are ugly, cosmetically. That's why, for example, I moved from the in the syndactylis, I moved from the skin graftless dorsal skin graftless technique to the volar technique, because dorsal scars are ugly. But I really like the interior, the posterior interosseous flap. I really like that. With that, I don't need to do I don't need to have this ugly scar. It probably is even faster doing an IOP than both flaps, probably. But in a future PULM talk, I will show my cases. I've done a lot so far. So thank you very much. Thank you, everybody. Kevin Little left already. He's busy. Thank you, Praveen.
Thank you.
Still, I'm not able to pronounce your surname properly. And thank you to all moderators. Thank you, Andres. See you next month. Gracias.
Yes.
Merci beaucoup. Dankeschön. شكرا بزاف. شكرا جزيلا.
Thank you. See you.